Hello there and welcome back to your antenatal education series. We are now on episode 5? No, we're episode 6. Episode 5 was on Monday, and that was the third stage of labour and the golden hour, and we hope that you enjoyed that. Today we're going to be talking about induction of labour. I know that lots of you have had questions about induction, so we're hoping to answer some of those questions today. I'm just going to put our share screen up so that you can see what we're going to be doing. So we're going to be talking about the membrane sweep and aromatherapy massage clinics that we run. We're going to be talking about why you might be induced, going overdue. We're going to be talking about the process of induction, what happens when you come in for induction, when your waters break before you start contracting, prostaglandin and prostaglandin's role in induction, artificial rupture of membranes, which is breaking of your waters, the hormone drip, the oxytocin, that's going to hopefully start your contractions going, and finally, for this week, pain relief during induction. Okay, so we're just going to go on now to indications for induction. So why might you be offered an induction? So round about 40 weeks and 12 days, you would be offered an induction date. So before this, we would be talking to you about what the induction involves and giving you information, booking your induction and that type of thing. But 40 weeks and 12 days is the day that we would suggest, or it's recommended that you be induced. And Heather is going to talk to you about that in a moment. The other reason you might be induced would be if your waters break before your contractions start. There's only a certain amount of time that can happen before your contractions, and then we would offer induction. The other reason would be to safeguard either your house or the house of your baby, and that would be on a conversation with your obstetrician and your lead midwife. That could be for many reasons. The three main reasons that we can think of off the top of our heads would be if your blood pressure was extremely high, if you had diabetes, or for the growth of your baby. If your baby was a little bit small, then we would be talking about induction. But those conversations would be happening with your lead midwife and your obstetrician. So Heather's now going to go on to talk to you about post-stage induction.
Thank you. Okay, so when we talk about people's due dates, so their estimated date of delivery, only 4% of babies are actually born on the dates that we've got on the scans. There's no particular huge science behind it, but I know that Dr. Lyndon Stocker was looking into updating the information on the scans, because all of the information you've got on your ultrasound scans, that is from algorithms from women who were pregnant back in the 60s. So things have changed quite a bit since then. So don't be too hard on yourself or fixate that date in your mind. It's really about listening to your body. Baby might come a bit early, or baby might be a bit late, or baby might be ever so comfy and not come until well past the date that we've predicted for you. So in Southampton, we class the appropriate time for induction as term plus 12 days. As Amy said, if there are health implications and things, it might be slightly different, but on this particular slide, we're just talking about if baby hasn't arrived 12 days after your due date. So you have your 40-week appointment with your midwife, and she may offer you a stretch and sweep, so the stretching of the membranes. This is an internal examination. If you've ever had a smear test before, it's quite similar to that. You remove all of your undergarments, all of your clothes on the bottom half of your body. You get into a position where you're lying on your back, and sometimes you might have to sit on your fists a little bit to tip your pelvis up. Because what we need to do is find your cervix, find the length of it, the dilatation of it, whether it's soft and stretchy, much like when Laura was talking about the vaginal examinations in a previous episode. So a membrane sweep or a stretch and sweep is something that we can offer you at 40 weeks. And if baby still hasn't arrived by your 41-week appointment, we can offer that for you again. Now, the membrane sweep is slightly different to a vaginal examination, and it can be quite uncomfortable. We're trying to go through the os, which is the name for the opening of the cervix, and then between the cervix and the membrane. So we don't want to pop your waters. We don't want to snag that membrane at that time, but it can happen if they're particularly delicate. You might have noticed a mucus show before we've offered you the sweep, or you might notice that comes away afterwards. And what the midwife will say to you as well is you might notice some bleeding or some pink staining of your discharge after you've had the sweep, and you might also notice some cramping, because what stimulation of the cervix does is it makes your uterus, it makes your body release oxytocin so that your uterus starts to contract. But that might kind of peter out after a few hours or a day or so, and baby is not making another appearance, which is why we offer you a repeat membrane sweep. So there are lots of reasons why you might feel around about 38 weeks, gosh, I'm ever so fed up, I would really like to have this baby now, but we don't offer you induction before your due date, okay, unless, as Amy said, there are the other implications to either your health or baby's health. There are national recommendations to offer an induction of labour, which you've seen on the slide there is IOL. So there are increased risks of baby requiring help with breathing at birth or resuscitation. Baby might require care on the neonatal unit. There is a risk of stillbirth, so when babies are born sleeping, and there is a risk of neonatal death. So when baby is born and is alive and fairly well, but sadly passes away in the neonatal period. So there are some risks that we have to acknowledge as care providers. It would be, I don't think nonsensical is the word, but it would be sensible to acknowledge these, and it would be nonsensical to ignore them completely. If you're induced because you're overdue, as you can see on the slide there, sometimes there is a thought that if we're asking your body to do something that it's not naturally doing on its own, that it might require an instrumental birth, which we're going to talk about in the next episode. So when we say instrumental birth, we mean the forceps or the ventouse, so the big spoons that go around baby's head, or the suction cup on the top of the head. But as you can see there, it doesn't increase a chance of an instrumental birth. Sometimes your body just needs a catalyst to get from where it is into full labour. It is associated with a small but significant decrease in the likelihood of stillbirth or neonatal death, and that is 3 in 1,000 compared with 1 in 1,000. So when we talk about statistics and things like that, sometimes it's difficult to visualize those numbers. So if you think about, if you live in a long street, there's probably about 500 people who live in your street, so 2 streets of people. So 3 people or 3 births out of that 1,000 would have a likelihood of stillbirth or neonatal death, compared with 1 per 1,000 if you have the induction. So if we help your body get into labour. Once we have started the induction of labour, it is likely that there are fewer babies who are going to be cared for in the neonatal unit, whereas women who wait for labour to start. So you can see the statistics there, 83 per 1,000 compared with 95 per 1,000. So this is a bit of a data heavy slide, but we like to give you that information so that you can look into it. And you've got the references there, the Cochrane Review 2018. So please do look that up, because we do keep saying it, but we don't want to make decisions about your pregnancy, about your birth, without you having a full complement of the information. So please do have a look at that information, and of course ask your midwife. But it is absolutely your right to question or challenge and say, actually, I don't want that. What are my alternatives? So that you can have a discussion about it. Okay. So we're just going to go on to the actual process of induction. So the first process, as I've said, would be the membrane sweep or the stretch and sweep, which can be offered to you. Before we start this induction progress, we need to know that your baby is head down or in the cephalic position. When you have a look in your notes, along all the observations, it will say long ceph. So it means that your baby is lying longitudinally and is head down. We need your baby to be head down. There are lots of births that happen when baby is bottom down, so a spontaneous breech birth. But if your baby is in a transverse position, so lying side to side, it's absolutely impossible for that baby to naturally go into the head down position without a little bit of manipulation and a bit of assistance to get into that position. So we need to confirm that baby's in head down position. We need to make sure that your general well-being throughout your assessment is fine, that you are healthy and well, that your temperature is fine, that your pulse is okay, that your blood pressure is stable. And we'd also want to have a look at your urine sample. So much like when you go to the midwife for your antenatal appointments, we dip your urine to see if there is any glucose, any ketones, if there's any protein in it, because that gives us an indicator that something else might be going on. We check your temperature and your pulse and your blood pressure. We want to make sure that you haven't got an infection. So we need to be sure of those. So we keep a steady eye on your observations. So again, like when you go to your midwife and we examine your abdomen, or we palpate, so you can see palpation just there, we have a really good feel of your abdomen to make sure that baby is in the right position, and to feel any contractions. So we might lightly place our hand at the very top of your bump, your fundus, to see how effective that contraction is. Now, what we feel in terms of pressure might not necessarily reflect the discomfort that you're having, but that gives us an idea of how tightly that muscle is tightening to start off with. So we would want to examine you in that way as well. If we are not sure from the palpation that baby is head down, we can ask for a positional scan, so an ultrasound, just to check where baby's head is, baby's presenting part is. We're also going to be listening to baby's heart continuously when we start induction, because when we listen with a Doppler, like we do in the antenatal clinic, we're getting a good picture for between 1 and 2 minutes. But what we need to see is for about half an hour, how well baby is coping with those contractions or the intermittent contractions, or even if you're not having any at all, we want to see that baby's heart rate is stable. So when we look at the CTG, we're looking at that to assess a varying number of things. So how many contractions you may be having within 10 minutes, how accelerative baby's heartbeat, if there are any dips. And if we're happy with that, if that's reassuring, then we can start the induction process. But if we're doing the prostaglandins and things, once it's done, we're going to want to see that reading again for half an hour afterwards, because we're doing something that your body isn't naturally doing itself, and we need to make sure that this baby is coping with that. Sometimes it's a little bit longer that you will have that the CTG running for, especially if baby's particularly active and it's difficult to get a really good continuous trace, or if we're looking at the trace and it isn't reassuring and we want to make sure, like absolutely sure, that everything is fine before we proceed with an induction. So on the induction suite, which you will find on labour ward on level D, we would do an internal examination, so a VE, vaginal examination, to have a look at your cervix, to see how long it is, the dilation of it, to assess with something called a Bishop's score, whether you are suitable to have a prostin to make that cervix more favourable, so shorter, starting to dilate, a bit softer, a bit stretchier, or an ARM, so that's an artificial rupture of membranes. We talk about SROM, which is a spontaneous rupture of membranes when your waters just go on their own. And we talk about an ARM, which is where we use an instrument to just snag your membranes. And much like the cord, no nerves in the membranes at all, but it is a little bit uncomfortable because, as you can imagine, we're doing the examination. We're able to open your cervix slightly, and we want to get that small hook through to be able to snag them as well. So that's the basic start of the process of induction, which is trying to get your body into labour. So what Amy is going to talk about now is if your waters break. So as I said, artificial rupture of membranes, but Amy's going to talk about when your waters break on their own. Okay.
Thanks, Heather. So I'm going to talk about when your waters break, but your contractions have not started yet. So sometimes this is quite common. You know, lots of people think, well, my waters will break once my labour has started, but it's not always the case. Sometimes your waters will break before the labour process starts. And sometimes that might be in a dramatic gush of fluid, in public, usually in Asda or something. But most of the time, actually, it's a little trickle. And sometimes it's difficult to know whether your waters have broken or not. I know we've talked about when your waters break in an earlier episode, and I think Laura talked about coming in to have your what we call a SROM check to see whether your waters have broken, and we would offer that to you so you could come in and have that confirmed. So most women will go into labour spontaneously once their waters have broken, and as you can see on the screen, about 60% of women will go into labour within 24 hours of their waters breaking. And as you can see further on, 91% of women, so the vast majority of women, will labour within 48 hours of their waters breaking. So you can see that you are likely to start having contractions on your own. It's not a given that if your waters break and your contractions don't start straight away, it's not a given that you're going to need an induction. But you will be offered an appointment at that point for an induction of labour, because if your waters are broken for more than 24 hours, there is a small risk of you contracting an infection via the little hole in the waters, and we don't want the infection to get into the amniotic fluid, obviously, because that's surrounding your baby. If you choose not to have an induction within 24 hours or at 24 hours, it's a rough guide, the 24 hours. It depends what time your waters break and what time you can come in, because what would usually happen is your waters would break and you would come in for an assessment, and then we would look to see what time the next available induction slot would be, and then we would negotiate and pop your appointment in. So if you choose not to have an induction within 24 hours,
sorry, Amy.
Sorry about that. I'll continue now. Then we can offer you additional. I've lost my thread now. I shall just get.
I'm so sorry.
That's okay. So if you choose not to be induced after the 24 hours, you can opt for having additional assessments for your baby's well-being. So we would offer you daily CTG monitoring so that we can make sure that the baby is okay. We'll be asking you to keep an eye on your baby's movements and make sure they're moving normally. Checking your temperature and how you're generally feeling. If you spike a temperature and you're feeling like you've got flu symptoms, then we would want to see you, because that is an indication of infection. We would also ask you to check the colour of your waters. We want them to be nice and clear or just have a pinky tinge to them, but we don't want them to be smelling offensive or any other colour such as yellow or green or brown. We've got the number of the labour line here, 0300 123 9001. This is the number that you would phone, A, if your waters break, but B, if you decide to stay at home and you are worried about any of the things that we've just spoken about. Okay, so similarly, if your waters were green or yellow or your baby's movements were reduced, we would then talk to you about immediate induction of labour rather than waiting, because at this point, it's not actually unusual for your baby to have had a poo when you're overdue, but it depends on the significance of how much poo is in the waters. But if that was the case, then we would be talking about immediate induction rather than going home and waiting. So I am just going to move on to prostaglandin. So Heather was talking about the prostaglandin pessaries that we use if your cervix is still long and firm and hasn't really been doing much before you've come in for induction. The prostaglandin is a small tablet that is inserted via a vaginal examination, and it tucks up behind your cervix in the posterior of your cervix, and that's the prostaglandin tablet. Okay, there are two ways in which we can give prostaglandin: the tablet or the pessary, which is a little bit like a small tampon that's impregnated with prostaglandin, that's inserted into your vagina behind your cervix, and then you can go home and wait for 24 hours. With the pessary, it's a slow release prostaglandin, so it releases over the course of 24 hours, and then we await for you to start contracting, or you come in the next day after 24 hours for reassessment. With the prostaglandin tablets, what would happen is the prostaglandin would be inserted behind your cervix. We would do another CTG monitor tracing of your baby's heart rate and make sure that your contractions aren't too much, sometimes very quickly you can start contracting. We don't want you to have lots and lots of contractions all at the same time. So we're just going to do that CTG monitoring just to make sure that baby is happy and that you're not contracting too much. And then you're going to go off and start mobilizing. You can go and have something to eat and a coffee, use the birthing balls to try and get your contractions going a bit more. And you're going to have that free time for about 6 hours. And then after 6 hours, we're going to repeat the whole process. So we're going to do another CTG, have a little feel of your tummy, see what's going on with your cervix since you've had the prostaglandin tablet. And hopefully the prostaglandin will have made your cervix nice and soft and start to shorten and hopefully start to open. That's the whole point. That's what the prostaglandin's for. So some women will find it quite uncomfortable because prostaglandin can cause a little bit of soreness in the vagina. There's not an awful lot we can do to stop that, unfortunately, but just to be aware that it can cause a little bit of redness and soreness. So after we've talked about what happens after you've had your prostaglandin. So if your labour hasn't started within 24 hours of having these, we'll be talking to you about your options. So that may be inducing your labour with further prostin. So it might be that you have a second dose of prostaglandin. Breaking your waters, so if your cervix has opened far enough and has shortened enough for us to be able to break your waters, we could do that. Or if your waters have broken in the meantime, we would talk about using the hormone drip that we'll talk about in a moment. The other option, of course, is resting and repeating the induction for 24 hours later. Obviously, these are conversations that you would be having with your obstetrician and the induction midwife who's looking after you. Another option would be to bail out of the induction altogether and discuss a cesarean section. But again, that would be as a discussion with your obstetrician. Trying to think, what else? Can you think of anything else for prostaglandin, Heather? You're on mute, my darling.
It's because I muted it in case my doorbell went off again. I was just going to ask, because a few women have asked me, certainly in clinic, at what point does it then have to be that the woman would go to labour ward? At what point of induction do we say, okay, we can't facilitate this on Broadlands anymore?
What do you mean, Heather? When labour needs augmentation?
Yeah, when we're talking about sort of outpatient induction, if we've used a prostin or a propess, if the CTGs are reassuring and the woman has got herself into labour and doesn't need the hormone drip, is it possible for her to go to the birth centre, or does she need to stay on labour ward?
No, absolutely. So if you have come in, if you've had a low risk pregnancy and the only reason that you are being induced is because you've gone overdue, because your baby is overdue by 12 days, then you could have a prostaglandin. And if you are contracting regularly and strongly and you're able to have your waters broken and your labour continues normally after that, then you could go to Broadlands Birth Centre, no problem. We don't tend to recommend that you go to the New Forest Birth Centre as part of that induction, because if your labour, and this isn't unusual if you're being induced, if your contractions slowed down or went off for any reason, we would then need to augment your labour. And the difference between induction and augmentation is that augmentation is to try and increase your contractions and get your labour going in the process that we should be expecting. If you were at the New Forest Birth Centre, that would then mean another transfer over to the Princess Anne again to have your augmentation or the hormone drip. So whilst I say yes, you can go to the midwifery-led environment, it would be Broadlands Birth Centre, not the New Forest Birth Centre.
Fab, thank you.
Okay. So breaking your waters. So we've talked a little bit about when your waters break spontaneously. We're now going to talk about the artificial rupture of membranes and what you'll hear called the term ARM. So if your waters haven't broken by themselves, it may be that we need to break them artificially with something called an amnihook. Hold the phone 2 seconds and I will just grab one. So I'm just going to show you what an amnihook looks like. And I don't want you to be scared about this at all. In fact, let me just come out of share screen so you can see a little bit more. So this is called an amnihook. And you really just need to be concerned about this part of it, just that little part. The rest of it is for the midwife's leverage and to hold it, okay? This whole thing doesn't go inside. Lots of people go, where's that going?
No.
It's just this tiny, tiny little bit on the end. And I don't know whether you can see, but on the end of the amnihook, it's just a little plastic hook. And that's enough just to, if you imagine a balloon full of water, the amnihook is just going to burst the balloon so that the water can come out. And this is very much what we use. I'll just come out of share screen again. Okay, so that's the amnihook. So we make a small break in the membranes, which is going to release the fluid from around your baby, and it allows the baby's head to come down onto your cervix. So it gets rid of this balloon of water that is usually between the baby's head and the cervix, okay? So it allows the baby's head to come down, pressing more firmly on the cervix, and that increases the strength of your contractions and hopefully gets you into labour, gets your contractions going nice and regularly. If you're having your first baby, the chances are, or research and evidence suggests that if we break your waters, it's far more beneficial to start the oxytocin drip, the hormone drip, sooner rather than later to get those contractions going and make sure that your labour gets going. You can speak to the midwives and the obstetricians if that's not what you want to do. You can leave it for a couple of hours before starting it, or at least speak about your options. But the evidence suggests that normal vaginal birth is much easier if you start the oxytocin when your waters are broken rather than waiting for your contractions to start. Okay, and I'll hand over to Heather to talk about the oxytocin.
Okie dokie. So yeah, the oxytocin drip, you might have heard it called a number of things, maybe a Synto drip, but we refer to it as oxytocin because that's the name of the actual the chemical itself. So it's an artificial form of the hormone oxytocin. That's the one that your body naturally produces for the uterus to start contracting. And chances are that your body is not producing enough of it, or your body isn't reacting to it. You might experience things like Braxton Hicks from about 30 weeks onwards. Some women get it much earlier and some women don't ever feel them at all. It's because your body has got receptors that they grow in sensitivity towards the end of your pregnancy, so that you're more sensitive to the effects of oxytocin. So we start a drip very, very slowly, because it might be that your body just needs a catalyst to get into that process of contracting. Because as we said in a previous video, what we want is for your cervix to be stimulated to release oxytocin, to contract your uterus, to push baby's head down onto your cervix to release the oxytocin. So your body might just need a little of that, or we call it like a tickle of oxytocin. So a very, very small amount. It would take probably, I think, trying to remember the numbers on the pump, I think 100 and something hours if we use the very, very tiny amount of oxytocin that we start off with all the way through your labour. Now, there's no point in leaving it at that very low level if your body is not reacting to it. So we observe your uterus's function over 30 minutes. We want your uterus to be contracting 3 to 4 times, ideally 4 times in every 10 minutes, for us to go, right, this oxytocin level, that is effective at this stage. We don't need to increase it, we don't need to decrease it. We want it to be regular contractions and strong contractions. So every half an hour, we review how well it's doing. If it's not doing it as effectively, we will increase it ever so slightly. We have a regime of how much we increase it and how it goes on. During this time, you will need to have continuous monitoring in terms of baby's heartbeat. So whether that is using the CTG, which is wired up to the actual machine itself, or using the telemetry, which are wireless monitors, it just very much depends on how effectively we can get not only the machinery working, but what position you're in, what position baby is in. We talked about an FSC in a previous video as well, making sure that we can get a really good trace of baby's heart rate, because referring to the first word on this slide, artificial. We are making your body do something it wasn't doing on its own. So we need to make sure that baby is on board with that and coping with that as well. So like I said, the stimulation of your cervix is going to be what helps you to release oxytocin. So just because you have this oxytocin drip, it doesn't mean that you have to be lying down on the bed, strapped there, unable to move, unable to mobilize. You can absolutely move about, no problem. It's great to be on the birth ball, or if you do want to sit in the bed, we can sit you right up. You can sit on the birth stool. You can do all of the things you need to do within range of the drips. Okay, so the tubes are pretty long. It goes into a drip in the back of your hand, so you will have a cannula before it is started, which is a little tube that goes into your veins because it is an intravenous drip, so it goes into your cannula. You'll also have some water running, okay, some fluids running. We call it Hartmann's. It's an isotonic fluid. It helps with your hydration, because while you can drink water and you can drink clear fluids, you can't eat anything. So we need to make sure that your body is getting all of the sustenance that it needs. There is a slight risk of something called hyperstimulation. Now, when we say that, we don't mean, you know, in one 10-minute period you've had 5 contractions and then the next you've had 4 and then 3 and then 4. We mean constant contractions where there's barely a break between them. As we said before, that contraction is not only squishing baby, but is squishing your placenta as well. So we want to make sure that it's not occluding too much oxygenated blood from reaching baby, because obviously it's very difficult for baby to cope with that if they're not getting the supply that they need, hence why we do the continuous monitoring as well. You might find that it can be quite uncomfortable to be induced, and well, I'm going to go on to talk about early or pain relief in the early stages of induction. Some women find that they've already had those early forms of pain relief when they're having irregular contractions, and that it's now getting a bit more uncomfortable. It is absolutely fine for you to request and have an epidural before the hormone drip starts. That's absolutely fine, no problem at all. As long as we've got the CTG on and we know that baby is coping with what your body's doing already, no problem to have the epidural first. So that's absolutely fine. So please do ask as and when you need pain relief at any point, whether it's induction or not induction either. In our last video, we talked about the 3rd stage, and Amy talked about the differences between the active 3rd stage and the physiological 3rd stage, where your uterus is being chemically stimulated to give you these contractions. It can often get a little bit tired after you've given birth. So we would recommend an active 3rd stage, which, as you'll remember, is having the injection in your leg to help the uterus contract afterwards, to prevent any tiredness from the uterus, leading you to have more blood loss than we would like. So that's a bit of a fly-by-night tour of the hormone drip. And again, some women do find it very uncomfortable. So excuse me, we take that into consideration as well, to make sure that we are on top of your pain relief too. So in those early phases of induction, so as Amy was saying, with the outpatient induction with the ProPress and the Prostin and things, it's still absolutely fine to have your paracetamol, warm bath, use the TENS machine, remembering not to mix the warm bath and the TENS machine because electricity and water are not friends. If you are in the unit, you can have dihydrocodeine or Oromorph, which is the oral morphine, the liquid. And of course, we can offer you massage. Now, whether that is a aromatherapy massage, or even if we just use the carrier oil and you're sat in a position and we are behind you, or even we've showed your birth partner how to do the massage, that's also something you're going to want, because contractions kind of feel like this low down period pain, and the stronger and more regular they get, the harder it is to kind of stay on top of it. So that's why we encourage you to really think about the different types of pain relief that you might like, even if you haven't spontaneously gone into labor. Movement is really good as well. We talked about swaying your hips, really moving into your hip muscles to get that real deep ache away. And you can ask your birth partner, or you've probably already got a plan, to utilize them for helping you move about. But again, if you're on labour ward and you do have the continuous monitoring, we can lift the bed right up so that you can lie on it with your forearms, and then you can sort of lean down into that contraction, have the birth ball behind you, so between contractions you can sit down. There's loads of different ways to mobilise during labour. Of course, if you have the epidural, it's less likely to be able to mobilise, but the hormone drip doesn't necessarily mean that you will have it, but it does mean that it is definitely an option for you as well. So like it says there, it's often more painful than a labour that starts naturally, and we'll try to facilitate as much pain relief and easing of that discomfort as you go along. So you can have a chat with not only your the midwife who will be looking after you for induction. We've got a really great team of midwives who run the induction suite, but also the midwife who looks after you once your labour really establishes and starts. And when we talked about pain relief before, remember we referred you to that website, labourpains.com, and they compare and contrast the different forms of pain relief and how they will affect you as well. So, excuse me. So do have a look at that website, have a look at the information we've given you. If you go onto the UHS website itself, you will find under the maternity section more information about induction of labour. And I know certainly when I see women at 40 weeks, if baby is not making an appearance, there's no Braxton Hicks, there's no practice contractions or anything like that, then I print off and give them the information leaflet about induction of labour, which is available on our staff net, so every midwife should have access to it as well. The movement one is really important. I think that sort of helps baby down through the pelvis, doesn't it, Amy? Sort of moving from side to side. I know Emma, who previously worked on induction, you'd know if she was on shift because you would see women scaling up to floor J, doing a crab walk on the stairs all the way up to get this baby rocked down into their pelvis. Yeah, you'd know she was on shift because you crab walk ladies heading up the stairs.
Fantastic. Well, thanks, Heather. So that brings us to the end of induction. As ever, please just ask any questions that you need, anything that we need to clarify for you, just write questions below and we'll do our best to answer them for you. On Monday, we're going to be talking about assisted birth and cesarean sections. Now, it can be quite difficult talking about when labour doesn't quite go to plan. So we're going to make sure that you have the support after Monday's session. I'll make sure that you have the support to be able to contact one of us directly to talk about any fears that you might have or any questions that you might have relating to what we're going to be talking about. So on Monday, we're going to be talking about ventouse and forceps and also cesarean section. So it's been lovely to see you, and we will see you again on Monday. Take care.
Thank you. Bye.